You. Gary, can I share my screen? Can you help me so I can share the screen and get the slides?
Yes. You're now co-host.
Okay, thank you. And thank you all for having me. It's always exciting for me to be able to share this information. I have a tendency to talk a little bit fast, so just slow me down if it's going too fast, because there's a lot of information that I'd like to share. And also, can you hear me? Garrett, can you guys hear me okay? Can everybody hear me?
Yes.
Okay, so let me just go ahead and jump right in. So I am a Care Partner Project educator, and I'll tell you a little bit about that. During the day, I am a private patient advocate, and I'm going to actually share with you just a little bit of my story, just so you can understand why I feel like I'm even capable of sharing this information today. So the gentleman up in the top left of the screen is my granddaddy, and he was actually the medical director of the Lorton Penitentiary Prison way back in the 50s, when it was still a working penitentiary. And he was the physician there, and my grandmother was a nurse, and I always was around his practice as a little kid, and always just around the healthcare system and doctor's offices, and I really loved it. And I thought, oh, I'm going to go do that, until I got to college. And I saw organic chemistry, and organic chemistry said, nope, you're not going any further. So I pivoted and I went to business school, but I never lost my desire, my love of science, medicine, doctors, all of it. So I went into pharmaceutical biotech, and I spent over 25 years in a corporate career on the delivery side of healthcare, and staying close to it. And then the gentleman in the bottom right, that's my dad. And daddy was diagnosed with a rare cholangiocarcinoma, liver cancer, bile duct cancer. And my whole perspective of the healthcare system just changed. And I went from, the delivery side, the doctor side, to the receiver side and the caregiver and daughter side. And it showed me just how fragmented and complex and scary our healthcare system is for people that maybe don't have a working knowledge of medicine and what's going on out there. So I left my corporate job and sat for a board certification as a private patient advocate. And now I have a company called Cancer Champions, and I come alongside and help families navigate the complexities of a cancer diagnosis. So that's my day job. But what I'm here with you guys for today is as a representative of the Care Partner Project. This talk is being brought to you by the Care Partner Project. Karen Curtis is the executive director of this organization. And unfortunately, her daddy had a lung transplant, a successful lung transplant, but actually died in the hospital due to events that should have never happened. And once Karen had that perspective, her whole perspective changed, and her life work now is to make sure, excuse me, that the general public that is interacting with the healthcare system, that we are smart healthcare consumers, and we can be good care partners for our loved ones when they're in the hospital. This is their website. They have hospital checklists, surgery checklists, just all kinds of information. And that's what we're going to be talking about today. So just the plan, so you guys know the roadmap. We're going to go a brief overview of how we got to where we are with the medical system, and then some really practical tips and resources that we can use to be effective care partners for our loved ones when they're interacting with the system. Now, everybody tells us, and most of us know this, like, we're not going to the hospital or the doctor or anybody by ourselves. Most of us bring somebody with us, but the challenge is that we bring somebody who really isn't any smarter than we are with the system, and they're there for moral support, and that's great. But we don't really, it's sort of the blind leading the blind a little bit. So what we're trying to do is change that. Now, In the United States, this is a horrible statistic. You would not think that this was happening in the United States, but there are about 36,000 people that get admitted or go into the hospital every year. And within that number, 1 in 3 of those people will needlessly suffer or die, unfortunately, from preventable medical complications. They call them never events because they should never happen, but they do. These events are things like staph infections, blood clots, there's medication errors, bed sores, falls. All of these things can happen in the hospital and they should never happen, but they do. And so like Karen's daddy, he made it through the lung transplant and the really sophisticated strategic part of his stay. He made it through. It was something as silly as a fall and a medication error that got, that was his demise. So why does this happen? And why are we here? I'm going to tell you just a quick story about this is a lady named Sarah. She's 67 years old, very active, and went into the hospital because she had a rotator cuff problem. She needed to have an elective orthopedic surgery to fix her rotator cuff. So she went into the hospital. Her physician told her it was going to be not a big deal, in and out surgery. She'd only be in the OR about an hour, and then she'd be home in time for the news in the evening. Sarah went to the hospital, didn't take anybody with her because it was going to be zip, zip, no problems. But when they got her in there and they got her into surgery, they noticed that the tear in her rotator cuff was actually more complicated than it had seen on imaging. So she was under anesthesia for about an hour and a half longer than anticipated. So then when she got out of surgery, she was in the recovery and she had a hard time coming out of the anesthesia. So they, just to be safe, kept her in the hospital overnight so they could watch her. Well, while she was in the hospital, she woke up in the middle of the night, disoriented, because she's coming out of the anesthesia. She had to go to the bathroom. So she got up to go to the bathroom. And as she stood up, she got a little dizzy, grabbed for the side table of the hospital bed, which we all know all those things are all on wheels. And as she stood up, the table zipped out from under her and she fell on the floor, hit her head. And she was on the floor for a little bit because nobody was with her and nobody knew that she had fallen out of bed. A nurse finally comes in, gets her, picks her up. Now they keep her again because they want to send her down for some scans because nobody saw her fall. So they wanted to make sure there was nothing wrong with her head. She actually did have a slight concussion. And so they kept her for another night. So now she's in there one more night. And as she was getting ready to be discharged the following 24 hours, she came down with chills and was spiking a fever. And they did some blood work and found that she actually now had an infection. And they're thinking it probably happened from, she was laying on the floor and she had a cut in her heel from where she had been breaking in some new tennis shoes. And like a blister, and they feel like that was the point of entry for the bacteria from laying on the floor. So now she's got a hospital infection. They put her on broad spectrum antibiotics. The long story short, this poor woman finally got out of the hospital, but not after being there for several days longer than anticipated, having broad spectrum antibiotics and all kinds of imaging. And it was really a frightening experience for her. And so what this shows us is that we have a healthcare system that is very reactive, right? Like we're really good at reacting to the issues. What we need to be doing is sort of preventing these things from happening. So why does this happen? Well, this picture on the left, this is probably closer to Granddaddy's time period, right? Where they had one physician, they had one nurse to every patient, very simple. The doctors were really good at diagnostics without a lot of technology. And it was a much simpler time compared to where we are today. And I mean, this looks like we're getting ready to launch, some kind of a space shuttle. There's monitors for everything. There are all kinds of telemetry, and everything is very complex now in our system. And it's helpful. I mean, it's helped making diagnostics much easier, but it's complex. Whoops, excuse me. So let's talk about this. So we've got the complexity of just drugs too. Drugs are much more sophisticated now than they used to be, and there's a lot more of them. We mentioned the telemetry and all of the monitoring that goes on. Diagnostic testing, there are so many tests. There's different blood work. There's just all kinds of tests that can be run. Back in my grandfather's day, we didn't have a lot of that. And he was just really good at looking at somebody and sort of being able to do some critical diagnostics. The physicians today are trained on tests. They know how to read tests. They're not super skilled at just sort of looking at a patient and being able to kind of see and have an idea of what's going on. Then we also have multiple people. So we don't have your just general practitioner taking care of you. We've got a doctor for your lungs and one for your heart and one for your head and one for your bones. There's just a million, lots of segmentation. And we talked about the monitoring and the alarms. And so with all of this, the healthcare system is complicated. And then we're going to add in the COVID factor. And we have now lots of healthcare professionals that are just pushed to the limit. And some of them are even leaving, which is leaving our hospital systems with even more skeletal staffing. And the ones that are there are sleep deprived and a bit frazzled. So that's what's happening externally. And then we have this is just a common research statistic that we forget. And when I say patients, I mean all of us. This is whether we're in a traumatic situation with the healthcare system, or even if we're just having a well visit with our doctor, we forget 80% of what they tell us. So that leaves room for a lot of confusion and error. And as a matter of fact, patients 65 and older, when they are discharged from the hospital, 3 out of 4 of them just either have an incorrect prescription plan with them, or they don't understand the discharge protocol. And what happens is we have a lot of people that rebound back into the hospital because they don't 100% understand what they should be looking out for when they get out. And so they end up going back into the ER for something. And so how are we going to make this stop? I mean, what do we do about this? And Einstein said, we can't solve our problems when we use the same kind of thinking that we've used to create the problem. So we're going to have to do a paradigm shift from reacting to proactive. And then that's our part. That's the healthcare consumer patient part. We can't wait for them to fix their thing. They're going to do them. We're going to figure out how we can be proactive and we can change how we engage with the healthcare system. So today, for the rest of this talk, we're going to talk about really practical things that you can do to be a good care partner for somebody in the hospital. We're going to talk about what we can look for, what we should say, when we should say it, and what to do. Okay, so we're going to move on from there. Do I have any questions just up to this point, Gary? Or is everybody following with me okay?
Yeah, I don't see any new questions.
Okay, perfect. So let's start with, this is what we all do. Whenever there is an information gap, at least for me, maybe not for y'all, but for me, I immediately go to Google or Bing or wherever you go, because I'm gonna educate myself, right? And this is a great tool that we have with the internet. But the problem, it's not a problem, it's a challenge. Not everything out there is truth, right? And there's a lot of opinion that's not backed by research. And so you want to trust what you're seeing, but you want to verify it. And how do you do that? Well, talk to the healthcare professionals. What sites would they recommend that you use based on whatever your diagnosis is or whatever procedure it is that you're getting ready to have? Where are some vetted resources that you can go get information? Because it's good to do research. We just need to make sure we're doing research that's relevant to our situation and truthful. So if you know people in the healthcare industry, they are good resources to tell you the websites they use. So just trust but verify what you're finding out on Dr. Google. Now, these are 3 sites that have been vetted, and I'm going to share them with you. And oh, by the way, this particular talk, I'm not going to share the slides because there's not a lot of information on the slides, but the information that is on the slides, I'm putting together in a one-page sheet that we can send out to everybody. So you're going to have these links and everything. So don't feel like you have to madly take notes right now. So these are 3 organizations where they actually go in and give a grade or compare hospitals based on these never events. Okay, so they are looking at the criteria, and the methodology of the rating is based on things that make a difference to the quality of the healthcare that is being provided. I'm just going to give you a little heads up here. If you drive around Arlington or drive around the Beltway, you can see the big banners: US News and World Report, ANOVA, best this, best that, best cardiac. Those are, for the most part, marketing. It's not to say that they're bad, okay, but they don't take in as rigorous a criteria in rating as they do when they're trying to rate the skill set of the actual people providing the healthcare in the hospital. So, you know, the US News and World Report, they also take into consideration from patients things like the cafeteria, the gift shop, how easy was it to park. Those things really don't, I mean, they're helpful, but they don't really matter when it comes to how are they doing against these never events, because that's really what's going to impact us. So I'm going to give you an example of one of them. The hospital's safety grade, Leapfrog, is an objective third party, and they maintain this grading system. And when you go to their site, if you just put in your zip code, you put in a radius of mileage that you want to look at, and you hit search, you will get the hospital matches that meet that criteria. And the hospitals will pop up and they will have next to them one of these big grades. Now, this particular hospital gets a B as an overall hospital grade. You can click into the hospital and you can see how does the hospital rate in falls, in post-op infections, in complications, and MRSA, all of that. So you can look at the never events and see specifically how that hospital is doing in those areas. This is a great resource to do. And Sarah, prior to going in for her rotator cuff surgery, it would have served her well to go ahead and go in and see, you know, maybe the fall risk in there was pretty high. Maybe that was not a good place for her to have her procedure. Okay, so moving on from there, another thing that you can do, that Sarah could do, is get a second opinion. So she had a surgeon that told her, you know, it doesn't look that complicated to me. I think I can do it in an hour. She said, fine, and went with this person. Maybe if she had had an independent second opinion, maybe they would have found something on the imaging, and the surgeon would have said, yeah, I think this is going to take, he would have been maybe more closer to what actually was going to happen. And when I say an independent second opinion, let's use, for example, MedStar. So we're going to go to MedStar Orthopedics and get an opinion. If we go to another doctor within the MedStar system, 99% of the time, they are going to corroborate what their colleague said. But if we get a MedStar opinion and then we also go out and get maybe an Anderson Clinic opinion, then you're having independent opinions and they're less likely to just kind of corroborate with each other. So you want to get an independent second opinion.
I've got a question here. What's a good site for doctor reviews?
I will have that. There's a couple different kinds. So you can go to the Virginia State Board, Medical Board, and so you can go there to review your physicians. It's also this is a good time where you want to talk to, if you know anybody in the healthcare industry, you know, people that nurses, physicians, they usually are a good resource too, to tell you kind of, yeah, you might want to stay away from that person because they see them working. But the Medical Safety Board and the medical certification boards in the States are good places to go sort of look at the physicians. And that's going to be on the one pager that I send you guys. So you'll have that link. Okay, let's go. Now, these are just some questions. These are just examples of some questions that you could ask an orthopedist or a surgeon, right, for a second opinion. You want to ask them if they use a checklist. And these things are all in the Care Partner Project website. So you can get these questions from that website. What do I mean by a checklist? Well, when they go into surgery, do they have like a checklist of what they follow through the protocol throughout the procedure? Because you don't want to forget things, right? This is how people forget sponges and things get sewn into people that shouldn't be there because there's no checklist. You want to know if they introduce yourself. Like, do you introduce me? Am I going to know everybody that's in the OR? So I know who all these people are. You want to ask who's doing the surgery. Now, that sounds crazy, right? Of course, the surgeon's doing the surgery, not always. So if you're in an academic center or somewhere where they are training young physicians, and Anderson Clinic actually has a fellowship program, they train young physicians. Sometimes the junior physician will be the one that's doing, suturing up, closing the surgery. They're not usually doing the bulk of the really where the expertise is required, but they could be doing parts of the surgery. So you want to know that ahead of time. And if that's not something you're okay with, then you stop right there. Like, no, we're not doing that. You also want to ask, will you be doing another surgery at the same time? That sounds crazy. Of course, they can only do one at a time. But a lot of times, especially when they're in a pinch, these hospitals will run ORs at the same time. So they might have a hip surgery over here and a hip surgery over here. And the surgeon is running back and forth in between the ORs because they've got junior people doing other parts of the surgery. So ask them, are you doing my surgery? And are you doing any other surgeries during the time you're doing my surgery? And you also want to know if they're going on vacation anytime after your surgery, because the worst thing is to have a surgeon do a surgery for you and then he's out of town for 2 weeks or she's out of town for 2 weeks. And if there's a complication or something comes up, you can't get a hold of them. So these are just some of the questions to ask. Okay, more practical things about what to do. Let's say now you're in the hospital. Okay, you've done your research, you know what hospital you want to go to, you know what your procedure's about, you know everything. Now you're in the hospital. You as a care partner want to take really good notes, however that looks like for you, whether it's a notebook, a spiral notebook, your phone, however you like to take notes, but you want to take copious notes for your loved one. And I'm going to explain why. How many of you guys know, and when I'm live, I ask this, but who a hospitalist is, or you've heard the term the hospitalist? Back in the day, the hospitalist was not usually the smartest guy in the room. He was the guy who graduated from med school or the gal who really didn't want to work super hard. And so they went to the hospital to be the house doctor. Well, that just meant that they were there sort of as a fallback for all the other physicians, for your GP and your internist and all these other physicians. So they were somebody that was there at nights and on the weekends. Well, what's happened in healthcare now, your GP, your internist, your family doctor, they don't step foot in the hospital anymore. They don't have privileges at the hospital. So the person that knows you the best is not the one that's going to be managing your care when you're in the hospital. It's going to be this person, the hospitalist. Now, they're much more specialized now than they used to be. They're not sort of, these guys are great now and gals, but they're managing anywhere up from 20 to 25 patients at a time, depending on how big the hospital is. And they are the quarterback for your care. And so all the specialists we talked about, they are all going to be coming in, and this is the person that's going to be coordinating all of that for you. It's important that your care partner know this person and let this person make sure they know you, because they don't know you. They don't have your medical history. They haven't treated you before. They're meeting you a lot of times for the first time. We think that just because we have electronic medical records, everybody knows everything. Oh, I'm just gonna pull them up and poof, they'll be everything. That's not how it works. All these hospitals have a platform for an electronic medical record. There's companies selling electronic medical records, and they've all bought one, and then they all decide they're going to merge. And that doesn't mean that their medical record programs are integrated. So you might be in an Inova hospital in Alexandria and now you're in an Inova hospital in Loudoun. Just because it's Inova doesn't mean those doctors can see your records. Not all the records are integrated. So you, as the care partner, may be the person that has the most accurate and most up-to-date medical information and historical information for your loved ones. So do not underestimate your value here. So let me see if I can't, there we go. So some of the things to talk to the hospitalist about, right, is you want to know, what are the goals? What's the treatment plan? What are we trying to accomplish here? What medicines are we going to be taking? Are there any medicines we should stop? Are there tests that you're going to be ordering, and why are you ordering them? What are you looking for? And then you also want to share with the hospitalist and with the physicians what your loved one's goals are. You know, they want to get out of here. They want to be out of pain. They want whatever the goals are. So it's up to you to work with the healthcare team to make sure that everybody's lines of communication are open. You want to keep track in your notebook of who's coming in. You're going to have all kinds of specialists depending on why you're there. So you could have pulmonologists, cardiologists, nephrologists. You've got nutritionists. You might have social workers. You might have physical therapy people. I mean, there are so many people coming in and out of your loved one's room. Know who they are, know why they're there, get a card from them, get their cell phone number while they're there, and know what their role is in your care plan. And then medication errors are one of the never events that should never happen. And it seems like a lot for us to have to worry about the medicine. We don't understand it. We don't know it. Why are we keeping track of it? But it's so important that you do know what medications your loved ones are on, the route of administration, and why they're on it. And the reason being is a pharmacy in a hospital, it looks a little bit like baggage claim. Like it is so frenetic in a pharmacy. There are a lot of different people doing a lot of different things. They're putting medicine and then they're sending it out. So errors can happen. And so these three websites that I have listed here, drugs.org, the ISMP, and the Beers List, are all places you can go to familiarize yourself with medications. And the Beers List especially gives a list of medicines that the elderly we need to be careful if the elderly are on these particular medicines because of our metabolism changes as we get older. And so the Beers List is another one that's is a good list to have. So when the medicines are coming in, you're there for your loved one. You want to keep track. So the nurses are going to say, hey, can I see your bracelet? What's your name? My poor dad, he was like, Dana, I've been in here for a week and they still don't know my name and they still keep asking me my name. I'm like, Daddy, it's for redundancy. They're doing that so they make sure they give you the right medication. You want to make sure it's the right drug and the right route. So for instance, your loved one may be on some kind of a drug, but they can't swallow, and it should be coming up as an IV, but it came up as a pill. So it's the right drug and it's the right dose, but it's not the right route. And that's when you need to say something, excuse me, I think this is supposed to be either an injection or an IV. My loved one can't swallow pills. And then for tests, you want to ask them, why are you ordering this test? What are you hoping to find? And when will you be coming to give us the results? Two things here. One, the cardiologist, the pulmonologist, and the nephrologist may all order the same test because they need it for their part, but they're not talking to each other. So now you're having three of the same tests. So just when you hear them, you ask, why are you ordering this test? Well, excuse me, could you just use the same test? The cardiologist just ordered that same test. And then they say, oh, of course we can. So you're just going to save your loved one from having to be run through the same test 3 times. The other thing is the results. You want to know, when are you planning on bringing the results and who's going to be talking to us about them? Because you don't want somebody to come in and talk to your loved one about results without somebody else there to hear, because remember, we forget 80% of what we're told, and to be able to write it down so you can have a conversation with the healthcare team. And when they do come in and it sounds like this, just I have so many clients that will just like sort of nod their head and go, uh-huh, uh-huh, uh-huh. And then they look at me and they're like, what in the world did they just say? And that is so normal, but we don't want to feel like we're not smart. But they have their own vernacular and they talk like this all the time. So if they slip into this sort of doctor talk while you're there, it is perfectly fine to say, I'm sorry, you're going to have to repeat that in language that I can understand. I don't understand what you're saying. And continue to ask until you are clear of what it is that this person is saying. Because the doctor, you guys, has got the most information and the biggest, he's part of the solution, she's part of the solution to the problem. You don't want to let them walk away with that knowledge without you understanding exactly what it is that they're saying. And honestly, they're only around for 7 or 8 minutes max. Like, so make sure you're asking them these questions.
Okay, we've got a couple of questions here. One is when you were talking about getting second opinions, aren't the doctors associated with a particular hospital?
Some of them. So yes. So some of them have privileges at different hospitals. Some of them work for the hospital. So like, for instance, Inova works for the Inova Orthopedics, they work for Inova. What you can do though, is if you look at your insurance, and oftentimes your insurance will have providers that are in different places. They're not just Inova providers. You may want to go over to MedStar. And if that's still within your insurance, go to Georgetown, see what Georgetown has to say. Their doctors work for Georgetown, but they don't work for Inova. So they will not necessarily be corroborating with one another. So that's what I meant by getting an independent second opinion, not necessarily independent from the healthcare system, that they work for, but independent of one another. Does that make sense?
Yep.
Okay.
And next question is, you were talking about tracking tests and meds. Shouldn't the hospitalist also be tracking this stuff?
Yes, they should. But there are, and they are. Okay. So I don't want y'all to think that like you're solely responsible for all this. You're not. Yes, they are tracking it, but mistakes get made. And it's a frenetic situation. They're tired, they're frazzled. If the wrong medication gets put into your electronic medical record, or the people downstairs in the pharmacy send up the wrong drug because your name is close to somebody else's name, anything can happen. We're human. And so we are there with our notes as sort of the redundancy to sort of make sure that we're checking the work of the people who are keeping track of everything. But unfortunately, the days of just sort of really trusting our doctors to really have it all together all the time, they're just kind of not, it's just kind of not there anymore. And it's not that they're bad or they're not smart or they're not competent. We've just added so much complexity into the system. There's just too many places where things can go wrong.
How often should we expect the hospitalist to visit the patient in the room?
So they come once a day. Usually you'll have a hospitalist will come and round once a day. They can come all different times. Sometimes they come super early in the morning. Sometimes they come late at night. I've had people visit people, at 11:30 at night. It just depends on the caseload and what's going on in the hospital.
Okay.
Good?
Yep.
Okay. So now we're going to get into like how you can really be like we've talked sort of about how you can be the eyes and ears for your loved one, but now you can sort of be their guard dog a little bit. Okay. In the hospital room, everybody needs to wash their hands when they're coming in. If they're going to be there at all, they need to wash their hands. We've made it very simple. There's those antimicrobial pumps that are right outside the door. People should be using that thing, everybody that walks in the room. Okay. So, and if they don't, sometimes doctors and nurses even forget or they get going, just remind them, excuse me, get your hands. And it's fine. They'd be like, oh, they do their hands. Bring your own antimicrobial gel and preferably a name brand, not necessarily Purell, but one of the name brands, not the dollar store ones, because they don't have as just one of the name brands. And why do you do this? Because your loved one, think about it, they're in their bed and they're touching the handrails and they're touching the tray and they're touching the remote and they're touching the call button and they're touching all these things that are just petri dishes for bacteria. And then they're touching their eyes, their nose, their mouth. And now that's how bacteria gets in. So we want to make sure that our loved ones are also keeping their hands clean with our own stuff.
Okay, we have a question here. Can you request a visit from the hospitalist? Say, if they come early in the morning and you have questions later in the day, can you ask them to come back?
You guys are great. Yes. So one of the things that you want to do, and when you're gathering up all that information of all these people that are coming in and out and in and out, get a cell phone number or get a contact number from the hospitalist, from all the specialists, from the nurse, from the charge nurse. They all have phones. Get their number and tell them, if I have a question, can I call you? Like if I've got these questions now, can I call you? The hospitalist might not be able to physically come back to the room right away, but you can get on the phone and call them if it's something that you need the answer to that day. If you don't need it, if it's not urgent, you don't need it until the next day, then you're just keeping your list of questions for when you see them the next day. But yes, you need to have their contact information so you can get a hold of these people whenever you need them. Okay.
And just so you know, we're about 9 minutes to 11.
Yeah. So so we're going to wipe things down. We also are going to make sure that our loved ones are wearing their socks, their slippy socks. This is to help prevent fall risks. If they may have been perfectly ambulatory before they got in the hospital, but being in the hospital sometimes, disorients you, you get a little woozy, you're on medicine. So you don't want your loved one moving around without their socks, without having help to the bathroom, and without using a cane or a walker, if in fact that's what they need. Alarms. It's so loud in the hospital. There's alarms and bonks and all things going. The nurses and the physicians sometimes get what they call alarm fatigue. It sort of sounds like a white noise to them. So if there's an alarm or something going off in your loved one's room and nobody is responding, you need to go out and get somebody and say, hey, I've got an alarm in here. I need a nurse to come in here. Okay. So we want to make sure that you're paying attention to alarms. You don't want to be in the hospital on the weekends if you can help it. So if you have an elective surgery, try to schedule it on a Tuesday or a Wednesday, so you'll be out of there by Friday. If you have to be in there over the weekend, you want to make sure you've got the information for all your physicians before they leave for the weekend. Find out what you should be looking for and when you should call them. You want to have somebody with your loved one 24/7. Either get friends and family to take a shift and to get their checklists and to be prepared. Some hospitals, if they can get you a sitter, if they have the employees, if you ask ahead of time, hey, can somebody sit with my person, for an hour or two or overnight, they can arrange, but that's usually just like a tech or somebody that's just to sit there to listen for alarms and to make sure that your loved one doesn't get up out of bed by themselves. Okay, this tip is worth this whole talk right here. So this is something that came into effect in 2005. There are some retired healthcare people that don't even know that this exists because it didn't exist when they were in there. If you were in your loved one's room and things are going horribly bad, to a point where you fear for their life, this is not like they need pain meds and nobody's coming, I'm going to use, that's not what this is for. This is for seriously, you feel like your loved one is something bad is gonna happen if we don't get some attention. It's essentially 911 in the hospital. You pick up the phone and you dial 0, you get the hospital operator and you say, I'm calling a condition help in room 1122 for John Doe. And you will have essentially a crash team there within minutes. They'll be at your door and they'll be attending to whatever life-threatening issue is there. This sounds kind of dramatic for some people. For some people, you may not know. I don't know. Is this life-threatening? Should I do that? I don't know. Go out to the nurse's station and just say, I am considering calling a condition help. And that will get everybody's attention, because nurses, doctors, nobody wants condition help called on their floor on their shift. Okay, so just keep it in the back of your head. Hopefully nobody would ever need it, but it's there if you need it. The other thing is confusion during the hospital stay. That's normal for some people. If once you've been in there a couple days, you just kind of lose your boundaries, your bearings, because you're on meds, you're not sleeping, you're in a weird space, and it can manifest looking like cognitive changes. You know your loved one better than anybody. If they were cognitively sound before they went in the hospital, it's a very slim chance that they have all of a sudden come up with dementia while they're in the hospital. But the doctors don't know your loved one, so they're going to call psych consult, neurology, they're going to call all these consults. You could say, excuse me, could this be just a staph infection? Could there be a medicine, are they having a reaction to the narcotics? Like, what could it be? Something else? 9 times out of 10, it's a urinary tract infection that's causing this sort of cognitive change. So speak up for your loved one before they go down this rabbit hole of neuroses, okay? Support the nurses. Show them your checklist. Say, I'm here to help. What can I do? Where's the ice chips? Where are the blankets? How can I help you? And keep the room neat. I've seen people where they act like they're just moving in, and it makes it very hard for anybody to manage and to work well. And if you're going to the cafeteria, ask them. You can bring them a cup of coffee. Now, discharge comes up quickly. Sometimes what will happen is you'll see the hospitalist on Friday morning and they'll say, yep, we're going to discharge him this afternoon. And you're like, what? You had no idea that was coming. So almost every day that you see the hospitals, just say, when do you think discharge? When do you think we might have discharge? And start making a list of the things that you need at home. You might need a bedside commode. You might need some extra set of hands. You might need some home health support. There might be a myriad of things that you need. So when you do get to discharge, you can ask the discharge nurse, these things I need, help me to arrange these things. The discharge nurse will go through all of these things with you. I recommend you record it. They talk fast. They cover a lot of information. And so you want to have the discharge information at your fingertips so you can refer back to it after you get home. And once you get your loved one at home, don't just say, well, that's good, we got through that. You want to follow them for about 30 days, check in with them once a day, see how they're doing, because sometimes we can get some bacteria or something in the hospital and an infection might be brewing. And they're getting us out of the hospital so quickly now that the infection might not manifest itself until 3 or 4 days after you get home, where now you might spike a fever. You can easily manage that at home if you catch it early with antibiotics just from the drugstore, right? You just call the doctor and say, this is what's happening, and they can manage it. But if nobody's watching your loved one and things post-discharge complications start to show up and nobody's watching, that's what happens when we bounce back to the ER and we end up back in the hospital. Ask for help. I love the villages. I love the whole concept of the villages, and you guys already get this concept of asking for help. You're not too proud to ask people for help. There's a couple apps, lots of helping hands, Caring Bridge, friends, family. This isn't the time to just sort of be stoic and go it alone. Go ahead and ask for help. It's perfectly fine. So that's us. That's the Care Partner Project. I really feel that when people are prepared and they know what to expect and they have much more confidence, that gives them a peace of mind that they are going in with purpose for their loved one. They know what to do, they know what to say, and they know how to get the information that they need. And so hopefully this will make you a much better prepared and confident healthcare consumer. These are the social handles for the Care Partner Project. This is their website, and that's me. If you know of anybody else that could benefit from this information, I give these talks via Zoom, I do them in person, and hopefully you will never engage with anybody that has been diagnosed with a cancer diagnosis, but I hope you would pass along my information to anyone that you know that might be disrupted by that disease. So that's it. Did I? Oh, got 1 minute to spare, I think.
Well, we have one question. This person said her mother was in the hospital. The doctors were telling me she was being discharged, but it was clear she couldn't go home.
Mm.
Everybody seemed reluctant to say that she needed to go to rehab or a skilled nursing center. Why would they be reluctant to say that?
There could be several reasons. Some of it could be insurance related, and that's just a deeper, that's a different talk. Like that's a whole different, insurance is a whole different thing. Medicare is a whole different thing. It may have been, it may have been, and this is a little sinister, that there were no beds in any of the rehabs or any of the skilled nursing, that they didn't have a bed for your mom. And so they were going to make her, send her home because they needed to get her out of the hospital, but they didn't have anywhere to put her. That happens sometimes where they don't have a Medicare bed. So they don't have anywhere to send them. The one thing as a consumer, and I didn't touch on this, but if you feel like your loved one is being discharged and they physically are not ready, okay, then you can put in an appeal and just say, this is not going to be a safe discharge. Those are the words you want to say. This is not going to be a safe discharge, and I'm going to appeal Medicare for an extra stay. I need an extra night. And what'll happen is that'll start the appeals process for Medicare, which will buy you an extra 24 hours while they're appealing it to see if they can give you additional time in the hospital. So that buys you a little bit of time. But that's the key thing to say is this is not going to be a safe discharge. I'm not doing this. And you can just say, we're not doing this. We're not doing it. And then appeal it.
Okay. One last question here. Does every hospital have a social worker to advise patients on post-hospital options?
Yes. It's either a nurse that's specifically trained for discharge, or it's a social worker, or most of the time it's both. And one thing I will say about that, they will give you guys lots of resources. They'll give you lists of skilled nursing, lists of rehabs, lists of home care. They will not say you should use this one or you should use that one. So you as the consumer sort of have to do your own due diligence on what's the best skilled nursing for my loved one, who's the best home health care for my loved one. And for that, you can either use friends and family that have some knowledge of these places, or you could use an advocate. But the social workers will give you the resources, but they will not point you in a direction.
Okay, and there's a question, yeah, there we go, about getting a hard copy of the presentation. And you said up front, you're going to be providing us with a one-page summary of all the links and the organizations and all the useful, valuable information.
Yeah.
So we will be posting that on our Nextdoor group and having that available in the office for anybody that wants it.
Okay. Yep. I'm happy. I'll do that as soon as we hang up.
Right. Well, Dana, this was absolutely incredible. I thought I knew a lot about how to handle a hospital stay, but you gave us so much new information. I'm so glad that we had you today, and I hope we're going to stay in touch with you. Perhaps there's something else. Where do you live?
So I am right outside of, I'm over in Mason Neck. I'm down in southern Fairfax County, but I go everywhere. And I will say I'm also part of a really interesting organization called Planning for Senior Life. And they are a group of vetted professionals. We go through background checks and all kinds of, vetting. And they're professionals providing legal services, health services, home care, assisted living, people that help with this, all kinds of things. And we could, do a panel. We do panels a lot.
Okay. Well, terrific. And so we probably won't see you personally in Arlington, but the power of Zoom And you know our providers, and I think some of the procedures that you went through today apply whether you're in Arlington or DC or wherever you are. So these were incredibly good tips. We are putting in the chat box our Arlington Neighborhood Village website. We'll have our slides from you up there in a day or so, I think.
Okay.
Email those to Gary and me, and we'll be all set.
Okay.
And anybody who wants more information about Arlington Neighborhood Village, you can always call the office at 703-509-8057. And I think I got that in the chat box. We had a wonderful turnout today, 30 people, enjoyed this conversation, and we wish you all the best. Thank you.
Thank you so much. Thank you all for having me. Have a great rest of the day and summer.
See you next week. Bye-bye.